Good morning, everyone, and I want to first start by saying thank you to Dr. Hari and to Yashoda Hospitals for the fabulous arrangements and for giving me this opportunity to talk about a subject that's very close to my heart. I'm going to be talking today about the intersection of interventional pulmonology and palliative medicine. And before I begin, I have a question. How many palliative care physicians in this room could I have a show of hands? I see one, thank you very much. That's the WHO definition of palliative care. Palliative care is an approach that improves the quality of life of patients and their families facing the problem associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So, I'd like a show of hands again. How many palliative care physicians in this room? I see more hands go up, and I'm very happy to see that. Thank you very much again. So there's this really interesting commentary which came up a while ago, which is about how interventional bronchoscopy is really endoscopic palliative care. And I met Dr. Dev from Singapore, and he it resonated with him. As soon as I said I'm going to be speaking about palliative medicine and intervention, he said, well, that's a lot of what we do. We do palliative care through interventions every day as interventional pulmonologists. This is Dame Cicely Saunders. She's the one person who brought in a very revolutionary concept of total pain. And that's about understanding every aspect of suffering that anyone with a chronic or terminal illness experiences, and then trying to address every aspect of that suffering to see how we may alleviate it. And she's been, she's credited with founding the palliative medicine and hospice movement. And her research, her lifelong commitment to providing high quality, comfort palliative medicine has led to the development of various institutions and the growth of palliative medicine as a field, not just as a primary palliative medicine field, but also as specialty palliative medicine. And that's the part that I'm going to approach going on with this talk. So, one of the things that I work on in my free time, besides medicine and pulmonology, is I work on death literacy. India, unlike other countries, does not rank very highly on what's called the quality of death index. I think the United Kingdom ranks the highest, but our access to palliative medicine is very limited. Less than 2% of our population has access to palliative medicine, and again, that is limited mainly to cancer care and to pain. Death is not something that's unexpected for most of us. These are the 4 roads to death that you see here. What you see as sudden death and terminal illness is just about 7% and 16% of the population. The others, which are due to progressive organ failure or frailty, makes up the rest of us who are going to see some amount of suffering. And as physicians, we are able to prognosticate and recognize when our patients need more than curative or restorative treatment. And it's really appalling that in 2020, we are providing palliative medicine only to those with terminal illness, which makes up less than 20%, just about 16 to 18% of the population. That means 80% of us may potentially see a rather slow and not very comfortable decline towards the end of our lives. The ATS has made a strong statement about changing the concepts of palliative care from the prior notions of palliative care being the part of medicine which takes over after all curative or restorative measures have failed. And we now recognize that palliative medicine and curative restorative care go hand in hand. In fact, palliative medicine goes beyond the end of life of the patient and goes on to support the patient's family through death and bereavement. When we start looking at the fields of interventional pulmonology and where the intersection of palliative medicine and interventional pulmonology lies, there's increasing attention being paid to it across the world. And we have a really nice commentary about palliative care and interventional pulmonology in the clinics by Dr. Ali. And they look at the different aspects in which interventional pulmonology can benefit patients with chronic progressive life-threatening illnesses, including lung cancer, where we have interventions addressing airway obstruction, hemoptysis, malignant pleural effusions. We look at COPD, We look at lung volume reduction that's done endoscopically. We look at bronchopleural fistulae that can be managed. And many other advanced diseases not limited to the respiratory system. When you look at cardiac, renal, and liver disease, here too we have non-malignant pleural effusions where the role of an interventional pulmonologist definitely comes into play in providing relief of suffering for a patient with a chronic progressive illness. The MD Anderson team has come up with a really interesting initiative, and that's looking at embracing technology in advanced disease. They're trying to build an illustrative set of cases to build the narrative required for the two fields to start talking to each other and collaborate more. Palliative medicine physicians tend to be averse to invasive procedures. However, we as interventional pulmonologists recognize that often the patients who benefit the most are the ones who are most severely affected. We've all seen, and there are studies that show that, for example, in central airway obstruction, the more severe the obstruction, the greater relief and the greater improvement in quality of life and relief of suffering for the patient with the central airway obstruction with tumor debulking or airway stenting. As we are noticing now with the greater advances in therapeutics, cancer too has become a chronic disease. We look at patients with stage 3, stage 4 disease who are now living longer. But they're living longer with the burden of the symptoms of the disease. And therefore, there is a need for the two specialties to communicate and collaborate to make sure that we're also offering improved quality of life along with survival for these patients. So these are the questions that we're trying to address with these narratives. When should a physician, an oncologist, or a palliative care provider, or a general pulmonologist consult interventional pulmonologists? And when should an interventional pulmonologist consult a palliative care physician in order to make the appropriate plan of care for our patients? There's various models of palliative care, as we know. There's primary palliative care or specialist palliative care. More recently, we're looking at integrated models of palliative care with palliative medicine physicians rounding in intensive care units. We've talked about an IPAL-ICU model of collaborative care in intensive care units. Maybe the wave of the future, or maybe the path of the future will be an integrated palliative care with interventional pulmonology model, or an IPAL-IP model. For example, you could have patients with COPD who would benefit from interventions as well as rehab, as well as the palliative medicine breathlessness support services. Trying to look at a chronic integrated palliative care model for certain patients who are going to live longer with greater burden of symptoms. We could consider joint rounds between pulmonology and between pulmonology or interventional pulmonology and the palliative care services, or adding on communication facilitators like social workers or physiotherapists or psychologists into our teams to make sure that we have a more holistic approach to the patient. This would be a different kind of an MDT for the more complex patients where you might have ethical conundrums to deal with in offering interventions to patients. I can tell you from my experience of attending sessions with our palliative medicine colleagues, they are of immense guidance to us when we are faced with ethical dilemmas about whether to offer interventions or not. Because let's face it, they've been doing this as a specialty for 25 to 30 years, and there's a lot that we can learn from them to incorporate more into our practices to offer better care to our patients. The Critical Care Society's collaborative came up with the concept of non-beneficial treatment and choosing wisely. As we advance in the technologies that we are able to offer to our patients, it's very important that interventional pulmonology professional groups also start addressing the concepts of choosing wisely and non-beneficial treatment, and try and generate data about what really should be recommended and where we might have certain difficulties in decision making. And that's when you need the specialist palliative care consult to help us provide appropriate, timely, and value-based intervention with honest communication with our patients. I'm going to use a couple of cases to illustrate these points, and these are just some things which have, some cases that have stuck with me in the way that working collaborative with palliative medicine has really added value to the patient's life. So the first set of x-rays that you see on the upper section are a gentleman who was 54 years old with an adenoid cystic carcinoma. He had it at multiple levels, and he'd undergone various stenting procedures over a period of 3 years. This gentleman lived in Bangalore, and he used to work in the Middle East. So he would come to Bangalore every 6 months to have a repeat procedure done he had a family to support. We worked along with this patient, understanding fully well that his disease was progressing. And as far as we could, we worked with helping him alleviate the airway obstruction with stents. But there came a point when the distal progression was such that there was no more intervention that could be offered. Now, these are multiple procedures over a span of 3 years, but when the time comes that you cannot offer any more intervention to the patient, we had already involved palliative care services. This gentleman finally moved to Mangalore, where he was taken care of by the Manipal University Palliative Medicine team, along with the pulmonology team at Manipal. And he had the satisfaction and comfort of knowing that he had achieved his professional goals with his work in the Middle East. He had taken care of his financial responsibilities, and we were able to assure that the end-of-life care was appropriate, along with adequate opioids and breathlessness support services offered to him. The other case in point is a gentleman who's about 79 years old, hard of hearing, severe emphysema, had a pneumothorax. As you can see, the lungs are really they're almost not there. It was a really tricky situation because at his age, offering him an intervention also came with a lot of risk. We counseled the family. We went ahead and offered interventions to the patient. We placed in an intrapleural catheter, had him with a Heimlich valve for a while. He had another pneumothorax on the other side. At that point, the family said, yes, they would be okay with proceeding on the other side as well. This gentleman underwent a pleuroscopic pleurodesis after resolution of the air leak, and he survived for another 5 years after that until he passed away about 2 years ago with an intracranial bleed. But in that much time, we were able to offer great quality of life. This is the kind of patient who very often, if they went only to a palliative medicine or very often people don't offer interventions to such patients. However, with the right kind of counseling and selection of patients, we can offer interventions with a great improvement in quality of life. This is also a conversation piece that's been noticed by other interventional pulmonologists across the world. We talk about a culture of bronchoscopy, which really is about understanding the patient's needs and providing that holistic care to the patient, understanding what their psychological needs are when they have severe problems like breathlessness. And maybe there is a niche field that's there for interventional pulmonologists who are interested in applying palliative medicine principles and developing that agenda a little further. There's challenges and pitfalls, obviously, along the road. Sometimes we wonder, and we say that, interventional pulmonology already is a long path. Most of us have spent many, many years getting here, going through internal medicine, pulmonary critical care intervention training. And there is a misconception that palliative medicine is another burden on us, it's time-consuming. However, I can tell you that very often, the stories that we carry with us are the patients who we are not able to help. And a little bit of collaboration with our palliative medicine colleagues and incorporating their training principles into our training principles might provide us with greater skills to handle the challenges of our work, communicate better with our patients. And that also has a positive effect for us with reducing burnout in our field. As we know, pulmonology, intervention, critical care are all high burnout fields. And having the input and training from the palliative medicine professionals or a collaborative approach can help us even safeguard our own health and long-term viability. The American College of Surgeons has launched an initiative which is about palliative surgery and surgical palliative care. And though this is more applicable to surgical oncology, I find it interesting that the surgeons seem to be taking a lead here in applying palliative medicine principles to their training programs. And we're also seeing critical care societies and the pulmonary critical care community coming together to make statements about the need for incorporating palliative medicine principles in our training. I think it's a natural extension that palliative medicine training becomes part of upskilling ourselves as interventional pulmonologists as well. So we've been looking at developing a palliative pulmonology research agenda and training agenda in India, and increasingly our national meetings and conferences have included topics which sensitize our students and our colleagues and peers about the need for developing more training programs which incorporate palliative medicine principles, as well as measuring the outcomes in terms of quality of life improvement on patients when we have a collaborative approach with pulmonology and palliative medicine. There have been a few books that came out in the last few years, which had a great impact on the social consciousness. When Breath Becomes Air by a neurosurgeon, a young man in his 30s, faced with stage 4 malignancy, was one. Being Mortal by Atul Gawande was another. And the conversation is shifting to patients being more aware of the kind of care they would like and that can be provided to them. And it is only fitting that we rise up to the challenge to offer our patients the highest quality of care, including palliative medicine, along with the interventions that we offer. I'm going to finish with a story of a patient who was very dear to me. A young man, 33 years old, with a history of a malignancy. He had a laryngeal malignancy 8 years ago and had undergone a total laryngectomy. He was a former sportsman, and then he turned to be a cricket writer. He developed hemoptysis and found that there was a return of his malignancy. He had a metastatic synovial sarcoma, which recurred in 2017, underwent embolization. Subsequently, he went in for surgery. All his therapies really did not help him. The tumor progressed. In August of 2018, he had progressive disease and presented with massive hemoptysis. His oncologist said that they've exhausted almost all treatment options. He was currently on immunotherapy, and he was going to be tried on the next line of treatment, but they really didn't know how much longer they would be able to give him. This patient, you know, it's quite an emotional thing when you're in the emergency room and you have someone who has rivers of blood coming out of his stoma and, you know, sheer fear in his eyes, and he looks at you and says that, "I need you to buy me 4 days, doc." And I asked him what he wanted with those 4 days, and he said, "I have unfinished business. There's a book that I'm writing that I need to complete. My daughter's birthday is in a few days, and I'd like to see her on her birthday." So we had an honest heart-to-heart. We went ahead with a bronchoscopy, and we went ahead and did a glue installation at that point. And following that, he had a rebleed, but you know, we told him that this could potentially be a procedure which may or may not reverse the course of his disease. I'm just going to play a brief video of what was offered for him. He underwent a glue installation first, large clots continued, he had a spigot placed, and subsequently after that, he was ventilated during this time. Subsequently after that, we were able to extubate him, and he went on to complete his book. He went on to celebrate his daughter's 4th birthday with her, and he also managed to take her to see a cricket match for the very first time. This gentleman got 9 more months. He underwent another procedure for a rebleed. His book was released, and it's now one of the contenders for the crossword bestsellers, for the best books in a certain, in the segment of sports writing or nonfiction. So it's really been a moving journey to hold some patients' hands and try and help them achieve their goals. And this is what we mean when we're looking at suffering as not just physical. You need to try and help the patient achieve their goals of, professional fulfillment, psychosocial stability, as well as being able to achieve the family's goals together. Last year, I had the wonderful opportunity of actually visiting the Dame Cicely Saunders Center to get a little bit more training in pulmonary palliative care. And I can only tell you that the experience has been so enriching. To be able to go and speak at what is considered the Mecca of palliative medicine was a great experience. And to see the collaborative spirit of pulmonology and palliative medicine at King's College was really a wonderful experience. I'm very happy to say that similar movements are taking place across our country as well. At the All India Institute of Medical Sciences, the palliative medicine residents rotate along with the pulmonology team, therefore providing a different perspective to the pulmonology residents, and they are also empowered to trigger palliative medicine consults. So the pulmonology residents, as well as the palliative medicine residents, benefit from this interaction with each other on the same patients. The Manipal Academy of Higher Education and Kasturba Medical College has a similar model where the palliative medicine team rounds along with the pulmonology, intensive care, cardiology, neurology, nephrology, oncology, and pediatric teams, therefore providing comprehensive palliative medicine, not just to patients with malignancies or with pain, but for non-malignant disease as well. We've now started a collaboration between pulmonologists and palliative medicine specialists from across the country. In December, a group of us met, 10 pulmonologists and 10 palliative medicine physicians, to start framing statements about how we would like training programs to now incorporate principles of palliative medicine in every specialty so that we now address the issues of suffering and improving quality of life for all patients, not just those who have malignancy or pain, but address the end-of-life care and quality of care for all patients across the board. Thank you very much for your patient listening.
Thank you for a very interesting talk, Dr. Rajani. I really like the way that you portray how we can actually integrate palliative and also interventional part of pulmonology. One question from me, how do you overcome the challenges that you face? Usually when patient already opted for palliative care, they probably will not be expecting any interventional procedures to be done on them. So how do you convince this kind of patient, palliative patient, to still receive interventional care? Thank you.
I think that's a wonderful question. I will say that in India, less than 2% of patients, as I said, have access to palliative care. So very often, patients are referred to us directly by their physicians or oncologists. And in these situations, it's really more about our judgment whether the intervention is appropriate or not. For example, you could have a patient with a pleural effusion. That patient has a malignancy. However, their primary complaint is not breathlessness and it's pain. And putting an indwelling pleural catheter may not be the best approach there, but actually using a nerve block for pain alleviation might be the better approach. I often find that unless we are trained in addressing these principles, we are quick to jump to offering solutions. So this is where interventional pulmonologists need to understand the palliative concepts. I think inviting and collaborating with our palliative medicine colleagues would be the ideal way. So now we have interventional pulmonologists in, for example, when you look at MD Anderson or Tata Memorial Hospital, which are the large cancer hospitals, these are the places where the palliative medicine people are getting more and more aware of the fact that intervention actually improves quality of life. So I think it will require a continued dialogue. When it comes to patients, I think honest conversation by picking up the phone with the palliative medicine doctor and telling them that these are the risks and benefits that we can offer is the ideal way to go.
Thank you. Any other question from the audience?
Thank you, ma'am. I have just a nice lecture. I have just one comment regarding the palliative care. Like, would we give the painkillers in the maximum OPI dose does not give the patient the relief. So there comes the role of interventional pulmonology or even the other patient has a chest wall pain. Maximum OPI does not help. So we have to have an alternative for that.
Yeah.
Like we have a endosurgical or like laser or something. That's very important.
Absolutely. I think that this is where it's really important that we work in a collaborative fashion. What the example that you mentioned is really about looking at your pain management services and looking at interventions that can be, so interventions are not necessarily just pulmonology interventions, but palliative medicine doctors, if they're aware of all the possible interventions, when you look at cardiology, for example, when you look at chronic end-stage heart failure, CRT itself is one of those interventions which can help in improving quality of life in those patients. But if the palliative medicine doctor is not aware of that, they may not look at offering interventions to the patient. So we do need greater dialogue between all specialties. Thank you. Thank you.